ready to come.
Thank you. And thank you all for being here. And thanks for the opportunity for me to come and present this information to you. Again, my background, my first degree was physics. Okay? I went on to medical school and I got a degree and became a foot surgeon. My area of research is knee osteoarthritis. So I'm in the section of rheumatology, which is under the Department of Internal Medicine at Rush University. My private practice is in physical medicine and rehabilitation. So even in the United States, I confuse everyone, whether I'm a physicist, I'm an internal medicine doctor, a rheumatologist, a physical medicine doctor, because I'm doing many, many things. So I do have a crazy, varied background. This is something I really cannot take credit for. This is something that DJO Global has come up with, and it's this PASS concept, which again stands for pain, alignment, strength, and stability. The reason I like it and have adopted it is because to me it looks like a target. This is my target for the therapy that I'm going to use on my patients. So the patients usually walk in with pain, like in hallux abductor valgus pain. So I have to address that. Okay? So one way to think about this is either this should be a prescription pad I'm going to give to my patient, so each thing has a prescription on it. All right? Or it's going to remind me, it should be up on the wall to remind me that, have I addressed their pain? Have I addressed the alignment, the strength, and stability? All right, so I need to do something for each of these if I'm going to be successful. If I forget one of these areas, there's a very good chance that this patient will be back in the clinic. Maybe 6 months, 6 weeks, 6 years, I don't know. But it's going to happen. They're going to be back if I don't address each one of these. All right, so again, for pain, it might be something as simple as, here, have some ice. It might be spot icing an area, right? For me as a physician, more than likely it's going to include pharmaceuticals, drugs, right? It might be, a compression device. It might be ice and compression. So it could be a very simple thing. It could be a very complex thing, right? It could be all the way up to installation of neuromuscular stimulators into the spine to block the pain pathways. And the same thing with alignment, right? Alignment might be something as simple as, I just want you to wear this insert, or I want you to change your shoes. I want a shoe with better alignment for your foot. All the way up to, I'm going to do a surgical correction to realign that foot. So again, each one of these needs to be addressed. The same thing with strength and stability, right? Strength might be, I'm going to send you the therapist, or I'm going to give you a TheraBand, and we're going to strengthen this area, or a towel, all the way up to very complex things like, again, neuromuscular stimulators and things like that. And then the same thing with stability. It can be very simple or it can be very complex. So we'll get into each one of these a little bit later. So this one is, we always have to start with what's a bunion, okay? A bunion, by definition, is just this red area right here, okay? And it is irritation over the bony prominence of an underlying problem, which is hallux abductor valgus. That's an orthopedic biomechanical problem, right? And of course, when you look at this, there are two different ways. One's called the Myers angular line, and that's just, you look at the foot and you classify how bad, how crooked is that toe, right? Is it grade 1, 2, 3, 4, that kind of argument, all right? The other way to do it is looking at the hallux valgus angle, and that's actually where you take the x-ray and you actually take an angular measurement from bisections of the first metatarsal to the proximal phalanx. And that's an actual angle measurement. And we use that to base our surgical calculations and things on. So again, an actual bunion is just the inflammation, not, right? So people get confused, a bunion versus hallux abductor valgus. If it's just inflamed like this, probably one of the easiest things to do is it's probably rubbing the shoe. You give them a shoe that has some kind of stretchable material on it, right? And those shoes are out there. It's relatively easy. Or you balloon the shoe, right? You can take a shoe stretcher, If you don't have one, you can send it down to one of the shoe people, and they can actually stretch the leather if there's leather in the shoe. If it's plastic, it ain't gonna work. So either leather or a stretchable synthetic material has to be used. So when you look at this, about 10 to 33% of the population has bunions. That varies from location to location, okay? 2 to 1 female to male ratio, so women are twice as likely. A lot of research on there, but I don't think anyone knows yet why that's true. Okay, is it hormones? Possibly. Okay, is it the fact that they wear goofy shoes? Funny looking shoes sometimes? Yeah, sometimes that can be contributing to it. Okay. So again, is it the Q angle up here at the hip? There's all kinds of variables that women have that men don't have. So there's a lot of research that have looked at all these things, but nothing really has come across as being definitive as far as why that's occurring. And of course, the other thing you look at is, there are all sorts of other foot deformities that are associated with this. Splay foot, which is a good example right here. Look at how wide, because of those bunions. She has a Taylor's bunion and a medial bunion. Hammer toes, again, that's a muscle imbalance problem. Metatarsalgia, more than likely because of the forefoot pressure. Plantar fasciitis, because a lot of this is based on proximal instability, right? If you have instability at the ankle subtalar joint complex, you're going to have pathology related to that instability. And again, flat feet, things like that, all the way up to rheumatoid arthritis, Ehlers-Danlos syndromes. What's interesting is hallux abductovalgus, and therefore bunions, was actually uncommon historically. So if you look at Greek and Roman art, you hardly ever see it depicted in the art. Okay. And you actually, when you look at archaeological remains, all right, they don't see bunions. You'll see splay foot, things like that, but look at the first met. It's okay, that's a pretty straight deformity. And finally, around the 1700s and stuff, you start seeing advertisements for pathological bunion deformities. So again, historically, we don't see this in the art and architecture, but you see that later on. All right, what about shoes? All right, is it related to shoe wear? Hundreds of studies out there on shoes and bunion deformities and things like that. Yes, a shoe can irritate, had hallux abductovalgus to create a bunion. Okay, but did that shoe actually cause that hallux abductovalgus? All right, and when they do the research literature, there is no direct correlation between a type of shoe and the actual bunion deformity, the presence or development of the bunion. So again, a lot of people believe that, oh, it's because I wore this tight shoe when I was a little kid, all right? But if you look at the research, it's not directly related to the footwear. We're talking about cause here, not effect, right? How about genetic disposition, right? Interestingly, 50% of bunions, if you're going to get a bunion, 50% of those people will get a juvenile bunion. So it will appear before the age of 20. So they'll have it as a child. May or may not be a severe bunion like you saw the photos there, but they can get a mild bunion deformity. All right? Most or half of those people that also have a relative who has it, which means there is a genetic predisposition, right? If your parents had flat feet and a bunion, all right, you got the shape of the articular surface of your joint from your parents. So more than likely, whatever deformities they had, you'll probably have that too. And again, when you look at the research literature, it's an autosomal dominant trait. So again, if your parents have it, more than likely you will have it too. It's that simple. Okay? Here's the problem, is what actually causes bunions? What is the underlying cause? One of the reasons this is difficult is because it's a complex underlying cause. Right? Oftentimes it's just not one variable, it's multiple variables stacked on top of each other until you actually have the physiology. So it has to do with the complex anatomy of that area. The big toe joint, the most biomechanical complex joint in the whole body. It is extremely complicated with a huge number of odd forces going across it. Okay? And again, I have a whole lecture, which I did before, about stability and instability within a joint. Okay? Stability and instability within a joint is caused by the actual shape of the bone itself, the articular surface of that, whether how congruous that joint is, the articular ligaments and capsular effects on that joint, and then finally the muscles that go around that joint. So when you actually look, when we go into the anatomy here, you see it gets complicated really fast. Okay? And then the other thing is, stability of one joint requires stability of the joint right next to it. Okay? So if you have proximal instability, you're going to have stability distally also. So we get into the stability of the mid-tarsal joint, midfoot, and forefoot when we talk about this. And then finally, it's just how are you walking? What is the gait that you have? All right? So we already talked about flat foot, and we'll get into the biomechanics of that in a minute. Ligamentous laxity, right? We had, who was that patient with the ACL injury? She was a fairly elite pole vaulter in Taiwan. And she had an ACL injury. And we were in a sports medicine center, and I was just standing here watching. I looked at her, and I said, do this. Right? Just hyperextend your arm for me. And she did that, and it went, right? That's a sure sign of ligamentous laxity, the ability to have essentially be double jointed. Then I asked her to take her hand back and try to touch, which, I can't do in that lot. And she was like that. And her mother was there, too. And her mother was like, oh, you mean like this? Like, yeah, clearly genetic predisposition to her ligamentous laxity, but think about it, it also probably set her up for that ACL injury. And it's going to set her up for other injuries in the future, like a bunion deformity and other problems. Rheumatoid arthritis, again, that's an autoimmune disorder. That's the body attacking itself. And so therefore, the synovium within that joint's being attacked by the body's immune system to destroy those cells. And then eventually you get a muscular imbalance or a joint imbalance from that too. The other one, which is we don't see a lot anymore, but if you amputate the second toe, almost always the big toe will move over, and that will cause a bunion deformity. Okay, a lot of neurological disorders, neuromuscular disorders, things like that. The shape of that articular surface again, is it a rounded shape or is it a flat shape? And again, that gets into the joint stability issues, whether that can rotate or whether you have stability because it's flattened. And of course, accessory bones just means a muscle. Accessory is just a extra bone, extra ossification center within the joint. These are not accessories, these are actual real bones, but these are actually sesamoids within tendons. But accessory bones look a lot like those. What happens is when you put that accessory bone within a tendon, it creates mechanical stability greater than if that was not there. It turns itself into a pulley system. So now it becomes much more efficient at creating a pull, a tension on there. So when you see accessory bones, there's more than likely going to be a muscular imbalance across the joint because of that increased stability due to that pulley system taking effect. Again, we talked about the hallux valgus angle, and that's the line between, on the x-ray, between the first metatarsal and the actual proximal phalanx of the toe. Normally, it should be slightly abducted, maybe up to 6 degrees. So you can see a bell curve for what's a normal population. And HAV, what you see is that shift over. Again, so what's going on is that's creating greater and greater. And that's usually how we determine, if it's more than 15, 16 degrees deviated, then we're going to do a surgery on that patient based on a few other criteria. So again, the hallux valgus angle is our diagnostic criteria from an x-ray to determine how bad that actual hallux abducto-valgus deformity is. Again, the orthopedic part of this, right? Here's where you get into the anatomy. And I'm not really going to get into this in detail because it gets complex very quick. But you can look in any anatomy book and you can see all the ligaments around the joint. There's a thing called a wing and a sling. And if you study the anatomy of the joints right here, and this is called the extensor hood, and this is there to keep that tendon to pull that toe straight. All right, the problem is you have large muscles up here, right? Extensor hallucis, flexor hallucis, things like that, that can be easily overpower the intrinsic muscles of the foot, which are very small, okay? And because, remember we said that that is slightly angled about 6 degrees, so when those large muscles contract and pull, it can pull it crooked. These small muscles that are inside of here are really designed to pull that toe to keep it straight. So really what you're trying to do is walk this way. I want everything in linear with that direction of walking, and I want to keep that as straight as possible. And so those vectors have to be balanced around that, so that all it's going to do is dorsiflex and plantar flex in the sagittal plane, in this plane, right? So everything about the anatomy is complex in that area, all right? Including the actual articular surfaces, right? There are actually 2 joints within one capsule, right? You've got one that's almost a ball and socket. So again, if it's a nice normal joint, it's going to be fairly congruous and curved. But then you also have the sesamoids right there sitting in the condylar groove. So there's the sesamoids here. And what happens is, this is a very weak connection. They can easily pop out of that groove and go crooked. All right? And that's, of course, what we see in hallux abductor valgus deformities. Okay? What's keeping those sesamoids in place also is a condyle plate, which is basically a thickening within that joint capsule. All right? And then there's a deep transverse intermetatarsal ligament that goes across to 2nd, 3rd, 4th, and even 5th. And it keeps that foot from splaying out when you step down. All right? And it's a very thick ligament that actually can be damaged relatively easy. All right? So the problem, of course, is that's an extremely deep, tight ligament to keep that foot splayed out, or keep it from splaying. What that means is that's going to hold that sesamoid relatively easy. But if this pops over, like we showed in the previous x-ray, right? If this starts to deviate like that, that deep ligament is holding onto that really well. So these did not change position. If that was superimposed back in, the actual metatarsal shifted over. And again, they did not shift over because of this deep ligament holding those sesamoids in place. All right. Again, like I mentioned before, is the weakest attachment with all that picture is going to be the sesamoids resting within that metatarsal head, right? It's a joint by itself, and it's not extremely well attached. So it's going to be easy for these to pop back and forth and move out of the way if this starts to deviate because of the external forces being applied across it. Okay. How come my videos never work? Oh well, that's fine. All right. So the other thing you have to remember is motion across this joint is triplanar, right? It's moving in all 3 dimensions. All right. The condyles are actually preventing abduction, adduction. It's preventing this from moving side to side, again, with compression, so when those muscles contract. All right. A round head right here is going to produce greater angular changes, right? So essentially the hallux is going to evert as it abducts due to the shape of that bone. Okay, so it's the inherent stability of that bone and the shape that it has. The one thing that you also remember too, believe it or not, every joint has a movable axis. Okay? How we refer to it in biomechanics is, well, what's the instantaneous center of rotation at this part of the gait cycle for that joint? Okay. So if you actually look at that joint going through its range of motion, you will see that the actual axis, when that dorsiflexes, moves first planarly and distally, and then proximally and superiorly. So it actually moves with that joint. Okay? The reason this is important for a couple ones. One is, if this segment here did not move to do that, all right, as it's moving through that rotational axis, you're going to have jamming of that joint right there, all right, as it comes up and forward. So A, that means that this segment has to move so this gets out of the way. All right, but B, all right, you need to design something that takes this into consideration, right? If my axis is moving, whenever I hook onto this as a brace expert, as a biomechanist, as an engineer, I have to take that into consideration, that this is a movable axis on here. And if I don't, I'm going to cause more stress inside of that joint if I don't allow that to occur. Okay, it's kind of going back to that PASS argument again. One way the body has to compensate for that shift of the movable axis is the ankle joint axis is actually deviated about 15 degrees to the direction of ambulation. Okay? What that means is if, let's say ignoring this line right here right now, if this would have been up here with respect to the rest of these, as I go forward and my ankle joint plantar flexes, I would have to have one-to-one movement across the forefoot with each degree of ankle joint plantar flexion during propulsion. Okay? But what happens here is you have a separate axis of motion going through the first metatarsophalangeal joint. All right, and what that does is it essentially allows the lateral column of the foot to drop to the ground and the medial column to come back that way. All right, by plantar flexing this medial column, by having this have an independent axis and the ability to go down, all right, it allows more dorsiflexion of the first metatarsophalangeal joint. All right, kind of a complex biomechanical term because it's based on the ability of the foot to go through that range of motion and plantar flex as it's supinating. But I can show you real quick. Who wants to be the model? All right. And again, so take your shoe off. Again, don't forget what's going on here is, you know, the fact that the foot is doing that, it's plantar flexing to the ground, at the same time allowing that to drop. Otherwise, if this was up in the air, I would have had jamming of that joint. Okay, she's got a little bit of bunion right here.
Yeah.
Okay, so the easiest way to do this is I can see right now that she's got a pretty flat arch right through here. I can see that she's getting a bunion deformity forming, so she's a perfect example of the lecture. The first thing I'm going to do is ask you to go up on your toes. Okay, what did she just do there? Okay, now do the same thing and so they can see you from this direction, from the back. Okay, now go up on your toes. Okay. As she did that, did you notice how she supinated and rolled to the outside of her foot? Right? Now, let me ask you to do this. This is going to be very hard. Go up on your toes while you stay flat-footed. Try to go up on your toes while your arch stays pronated. She can't even do it. Very difficult to do, right? So that's just a demonstration of what I just said right there, right? The fact that to get her ankle joint to plantar flex, she has to supinate her foot and then plantar flex the medial column to get it back down to the ground. Okay, so it's, again, supination of the rear foot is stabilizing that rear foot so that she can now plantar flex and get increased range of motion. Another way of demonstrate that is, you know, now she'll be my patient and sit here. Okay? So when I see a bunion deformity like that, my first question I have is how much range of motion can I get out of this in the optimal position, right? The optimal position on these is going to be what? Inverted, she just did right there, right? Okay? And plantar flex the medial column, that picture again. Okay? So when I do that, then I can take a measurement from there to there, right? So I can actually see how much, you know, had I made an insert or a device or a brace that would allow as much motion as possible, this is how much she can possibly get right now. So I'll take that measurement to see, you know, can I really get any motion out of this, okay? When I want to find out, you know, what's more than likely what's going on when she's stepping down, if she steps down and pronates and my hand is now the ground, right? And I try to dorsiflex it, I don't get a lot, right? So look at that range of motion from there to there versus the range of motion from here to here, right? So I can actually look at the difference between those two to understand her mechanics, right? What's going on across this foot from a supinated position to a pronated position, all right? That is exactly what that slide says too. So they're all saying the same thing but different ways, all right? So thanks. I'll probably use you later again. Okay, I'm going to skip that argument. All right, let's go to the gait problem now. Okay, the purpose of gait is to move my body from point A to point B. So this forward progression of momentum. All right, I have to push against the ground with more force to make me go forward, right? So when I'm standing here like this, for me to start my propulsion to go forward, I have to tell my muscles, my internal muscles, to counteract the external ground reaction force from body weight and gravity to say, okay, start rolling forward and now push yourself forward, right? So I've got to overcome those forces, okay? Since the contralateral limb is swinging forward at this time, if you look at the external ground reaction force vector, it's going to really be trying to shove that big toe joint like I was doing on her to the medial side up and out like that. You know, and so a good way of just demonstrating this is, you know, you're going to strike supinated, pronate to the ground, and now at this point, I should resupinate my foot as I start swinging forward. If I have a abnormal foot configuration and I stay pronated, right, at the same time now that this foot is swinging, the ground reaction force vector is just shifted slightly because it's following my center of mass. At the time that my foot is pronated now, which creates an unstable configuration, again, proximally to that. A lot of times, if you've heard people say loose bag of bones, that's one way of thinking about when the foot is in a pronated position. So if my foot is pronated at a time it should be supinated, it's another way of saying it is unstable at a time it should have been stable, right? So for the same reason, you know, she could not go up on her toes pronated. She had to resupinate to get that stability so that she can jump. Okay, again, that locks those bones together, gets into biomechanics of the mid-tarsal joint and subtalar joint, so it has proximal stability. So again, so if I'm rolling forward and my foot is pronated, at the same time that ground reaction force is now going like this and following my center of mass of my body medially, that ground reaction force is going across my big toe joint at that period, and it's shoving that big toe joint off to the side, creating that bunion deformity. So just an abnormal gait is going to cause force vectors that will eventually lead to a bunion deformity, right? Now, I do that 10,000 times a day, and I keep doing that for 10, 15, 20 years. Eventually, those bones are going to adapt to itself, right? You've got Wolff's law and Davis's law. Both of those consider one's an osseous response to those loads, and the other one's a soft tissue response to the loads, okay? Soft tissue under prolonged tension will eventually stay in that position, right? And bone will grow towards a force vector. Both of those are seen in the bunion deformity. You see osseous growth and you see soft tissue deformities forming around that. Okay? Now you start looking at the muscles around that joint during the gait cycle, things get complicated really fast, okay? And again, research shows, you know, that EMG activity of pronated foot will have greater activity of the AD ductor. AD ductor. Look at the vector pull on that, right? So if this muscle is hyperactive, it's going to pull that over. Guess what? There is an opposing muscle. It's not pictured, but it's right here, called the abductor hallucis, right? It's on the medial side of your foot. In fact, if you've ever seen a patient with a bunion deformity, especially the early stages, they will get cramping right here. This muscle will go into spasm because this one is overpowering it and pulling it. And not only that, look at the extensor tendon now, right? So if this toe starts to go crooked, okay, the vector pull, they call this like a bowstring effect. And we have another slide on that. But you can see that on this picture also, is once that starts to deviate and get pulled over to the side, the net pull is to pull that big toe over, okay? And what's interesting is these spastic contractures actually begin before the hallux is on the ground, which I don't think we know why that's true yet. Okay, why is this muscle, this intrinsic muscle, going into spasm even while I'm going in through swing phase before I even hit the ground? Okay, that's a good question. I'm not sure I can answer that one yet, but the research shows that that's true. Okay. Remember we talked about metatarsal joint, subtalar joint stability is required to go up on your toes like that. You have to have the proximal stability. One of the reasons is if you look at the peroneus longus tendon, okay, it comes down, of course, from here on the outside of the foot. It wraps around the cuboid, and in a supinated position, which means the arch is up a little bit higher, right? A normal arch is a better way of saying it, right? You can see that the vector pull is down and over, right? So if you look at that vector of the angular pull of that tendon, it's down and over. Well, it hooks right here in the medial column of the foot, right? So its job is during gait, and this is firing, is it's pulling the medial side of the foot down and lateral to stabilize the entire medial column of that foot right here, okay? So here this foot is going through pronation, supination, and you can see what's going on is it's dropping, it's going up, right? So this is dropping, and this is going back up. Well, as this drops, look what happens to the vector pull of that tendon, all right? You have less of the downward pull and more of the lateral pull. What that means is now this whole column becomes susceptible to the ground reaction force pushing up on it, okay? Because before it was this tendon stabilizing the medial column of the foot so that it could stay on the ground and go up in the air like she was doing, right? That's what was stabilizing the medial column. As soon as this foot goes into that position right there, now the ground reaction force vector has a much greater mechanical advantage because I don't have an internal muscle moment to counteract it. So now it's going to push up there much more efficiently. So if that's happening, going back to the gait cycle where I'm doing this, where I'm swinging this leg forward and my foot is excessively pronated, that ground reaction force vector, remember, now is pushing up and over like this. So now that foot is going to respond to that. This is going to become unstable, and this whole medial column is going to go crooked, right? It's going to get shoved up like this. Well, where's the toe at? If you're wearing a pair of shoes, where's the toe at? There's a shoe in the way, right? It's not going to let that toe go over with that whole medial column like if you would when you were barefoot. Okay? If you have a shoe on, there's something in the way, yet intrinsically this is still going on inside the foot with the ground reaction force vector still affecting that joint. Yet the shoe now is what's causing that toe from keep staying straight like the archaeological digs showed, right? Even though they might have a splay foot because of it's responding to the abnormal ground reaction force vector, they did not have a shoe on to pull it back over to create this crooked deformity now. So there's where the shoes come into play. This is why we don't see this in unshod populations, right? We see this in modern Western societies that have started wearing shoes, and maybe, concrete has something to do with it too, I don't know. So again, that's why pronation and understanding the mechanics of the subtalar joint and metatarsal joint are relatively important, okay? I'm going to take a minute and deviate now from the lecture because that's where this comes into play, all right? I'm not sure, my slides I'm not clear, but you never give one of these without one of these, right? This is one part of the PASS argument, and to me this is more, strength and stability argument. This is the alignment argument, okay? I need that proximal alignment up here. I need this thing to stop doing this. And I'm going to do that with an insert, right? And the reason I grabbed this insert, and actually it's just because, earlier today she was complaining about her foot, and so I really exaggerated this. It's a low temperature material, okay? I'll give you historical background real quick. Right now, if I want to make a functional orthotic, if I want to create an orthotic as a physician, I take a plaster cast of the foot or I laser scan the foot, and I take a copy of that patient's foot with a handwritten prescription or whatever, and I'll have to say directions, and then I ship this off to a third party, a lab, who's never seen my patient before, right? They look at the cast, they look at the three-dimensional shape, they look at my scribblings and say, you want to do what? Okay, you want to invert that rear foot? Okay, I think I can do that. And again, they can type in the computer nowadays, you just do it inside the computer. All right, fabricate it, either CNC mill it, 3D print it, hand press it, vacuum press it. There's different ways of doing the same thing. Well, this all came about because 50 years ago, when people started thinking about this, we did not have very good materials. We had steel 50 years ago, that's what they used. Stainless steel, right? Patients hated it the first time we put that piece of stainless steel on their foot and started beating on it to try to get to shape their foot. Just like patients hated it when I took a 400-degree Fahrenheit piece of polypropylene and pressed it against their foot. They didn't like that, so I said, fine, I'm going to take a copy of your foot and do this to the copy of your foot after I made the adjustment, right? The reality is this. The patient was in front of me. I saw the problem. You know, she's a perfect example, right? I could see her problem. Not you. I was looking at her. She was the perfect example. You're a different problem, okay? I saw what her problem is. She came in and complained about a bunion. I looked at her rear foot. I saw that there was a problem with it, that she has pronation, okay? In my mind, I basically, and can I borrow your shoe? Because you're like the perfect, you get the perfect shoe for this. I see him because he's got a very flexible pair of shoes, okay? All right? She probably walked in my office looking like this, right? And sometimes you see the shoe broken down like that too, right? So her rear foot is everted. Her forefoot is inverted. Why? Because there's a functional axis right here called the metatarsal joint, right there, that's moving and doing that, okay? In my mind, after I saw her sit there and pronate, I did this to her foot. I might have taken a measurement, okay? Or I might just have her stand and do that. You know, in my mind, I'm like, oh, if I could just take her foot and do that, right? If I could just invert her rear foot, evert her forefoot, okay? This is a functional segment. When one part of a segment goes one direction, the other part has to go the other direction, okay? If I could just take a piece of plastic, put it up against her foot, twist it like that, and then push a button and say, hold that position for me, right? That's what I really wanted, okay? Because I didn't have that, I had created a whole nother system, right? Called O&P, P&O, orthotics, prosthetics, and a whole system on how to create these things out of plastics and metals. As opposed to, oh, I just wish I had this. This is a low temperature thermosetting plastic, okay? It came from a company that's called Exos. Exos is famous for they came up with a formula for creating this physiological low temperature. That means that I can, when this is hot and moldable, I can put it against soft tissue and it does not burn it, okay? And they came up with it for arms and wrist things. So they had splints up here, and they had the bow closure, so it's really cool stuff. But they said, hey, let's do the same thing for lower extremity. The difference, of course, is the forces going through lower extremity during gait are considerably higher than the forces around that, like wrist fracture. So they had to change the formula, and to do that, they put carbon nanotubes in here, and that's why it's black now. All right? That's why they also made these colorful little, or not colorful, but designs in here to replicate the carbon nanotube, okay? The base material is nylon, very similar to nylon 12 on 3D printing. There's some extra, proprietary stuff in there for low temperature, and then there's about, maybe about 16, 17% of this is carbon nanotubes, and that's what gives it that strength, all right? So this is now still hard, all right? But I can heat this up and change the shape like that. Because it's low temperature, it also means fast, right? It doesn't take a lot of time to get to that temperature, and it cools down really fast too. So now, with this, is I can actually control my rear foot. Get the heat gun? All right? So here's a good example. What I did, I'm not sure if you can see this, but look at how much inverted I did her rear foot. Okay, I exaggerated it based on her complaints and what she was saying. All right, so the fact that there's, the rear foot got inverted, the forefoot got everted, I have a piece of plastic here now that's going to hold that foot to not allow that to occur. All right, on her, I overdid it, and I overdid it on purpose. Okay, to fix this, all I've got to do is take a high temperature heat gun, and again, all I'm going to do on her is actually drop that arch just a little bit. So I'm going to spot heat just the arch area, all right? And it's going to be about 30 seconds, maybe a minute, depends on how flexible I want this. But since I'm just dropping an arch, it won't take that long. There, it's already pliable. And again, all it is, I just touched it just to see how pliable it was. And look, I'm hanging on to it. I'm not burning my hands, even though it's warm, okay? And so for her, you can see, look how much inverted that rear foot is for those people right behind it. All I need to do is to fix that is to basically just lean on it, okay? So I'm going to just drop that back down to the ground. So I'm just using the tabletop. Another way of doing this, I could have her stand on it, right? Because she was complaining about right away, oh, it feels like it's too high. I'm like, oh, get used to it. Now she come back to my office a week later saying, yeah, I don't like this. But that's how quick it was for me to fix her problem. If this was a custom device fabricated in the laboratory, what do? If I'm good, and depends on the plastic or the foams that they use, if I have access to it, I could do this, but it would take longer. Polypropylene is about 400 degrees Fahrenheit to get to before I can start changing it, okay? This is about 140 degrees Fahrenheit at the most. That should really, usually it's about 120. And so now, I just did a little bit. I didn't do her full correction, because I still want to get a little bit of Ferrous post out of there too, okay? If I wanted to do the opposite of that, okay, if I wanted to invert her rear foot even more, I could do the same thing. I'm just going to spot heat the medial column of this, because that's what I'm going to correct. Because really what I'm doing is I'm taking a foot like this, or a rear foot, and I'm going to invert the whole device, right? Well, if you invert the rear foot on a piece of plastic, you also invert the forefoot, right? So just like that shoe, what I had in my hand, when I do this, I want to invert the rear foot, but then drop the medial column, or evert the forefoot with my hands, right? So I can do it this way, just twisting it with my hand. I can do it this way by putting it on the tabletop, holding that rear foot, and then dropping the forefoot back down to the ground. Or I can have the person stand on it, on maybe a piece of foam and stuff, and kind of do the same thing. So again, the difference with this is you saw how quick it was for me to adjust that. I don't have to send it back to get it remade. Okay? There is such a thing as serial orthotics too. Like if somebody keeps pronating, okay, if I take this shoe and I keep doing that 10,000 times a day, right, and I eventually stop, what's the forefoot position of the shoe going to stay in? All right? The material of the shoe is not unlike the soft tissue of our body, is you will get soft tissue contractures across the forefoot, just like this shoe did by twisting it. It's called a forefoot supinatus, okay? Now, if I take the orthotic and I have them step on this and it stops this from happening again, because I'm controlling this, that soft tissue contracture will gradually come back down to the ground. Yet, if I have a piece of plastic in the way that's trying to hold that position the way it was to begin with, the patient's going to complain that, this felt good for a while, but now it's kind of hurting me. Now I feel like the arch is too much, right? Relatively easy to do with this. Again, I just heat it up and lean on it and drop that arch down, okay? On the old way, I'd have to basically make another pair of orthotics. Well, at that cost, custom orthotics, if I'm doing a bunch of them, gets pretty expensive. These are relatively inexpensive, and I can also adjust it like that, okay? If this is a sports medicine patient or someone who I understand who's maybe an engineer, or, I can also tell them that, well, you can adjust this yourself. Let me show you how. Especially this, if I overcorrect it, the easiest way is like, again, just lean on it and drop it a little bit. Now you can overcorrect it, you can undercorrect it. So there is the expertise of your ability to do this, okay? But again, the point of this is I need to correct the rear foot position, subtalar joint, metatarsal joint, the joints proximal to the big toe joint have to become stabilized if I want this to be corrected. If I just give them a splint, it's not going to work probably. I didn't change their underlying biomechanical problem. I may have aligned their big toe joint, but I have not aligned the kinetic chain all the way up. And I do. When I do an exam for a big toe joint, I look at everything all the way up. Okay? Quite often I see a tight medial hamstring, right? If I see a tight medial hamstring, I need to stretch that because I have no hope of stopping their pronation from occurring if during the gait cycle my medial hamstring is pulling their foot and their whole leg like this to the inside. So I need to understand the mechanics all the way up. Okay? So it's not just giving them a splint, it is stabilizing the proximal segments, looking at the muscle stability and strength, the PASS again, to make sure it's going to work. So here's an example of that, right? One of the things we know is, remember the proteus longus? That's what's attached to it right there, is key to stabilizing the medial column of the foot. So usually when I have a hallux abductor valgus deformity, I see a weak proteus longus muscle right here. All right? So I need to work on strengthening that muscle, and more importantly, it's the neuromuscular rehabilitation of that. Okay, quite oftentimes I might even ask them, have you sprained your ankle? Is there some reason why you have neuromuscular problems, deficiencies right there? And so, this particular one, you can see they're on a balance board and they have a neuromuscular stimulator. And so the therapist is actually working, it's a wireless unit he's got in his hand, he's actually working on stabilizing that. Okay, I'm not certainly an expert, I'm not a physical therapist, but I understand the value of this and I can get them to a physical therapist who can work on that. All right, so this is key. This is, that, again, part of that PASS, the strength of that proteus longus. All right. Okay. This is going back to that muscle loading paradigm again too. This is basically a muscle free body diagram showing where the vector pulls of each of those structures are. And look at how all of those are pulling it that way, right? That's why that toe goes crooked. It's a muscular imbalance, okay? And that muscular imbalance is there initially because of the alignment issue, right? The alignment issue probably came there because there was a dynamic gait issue, right? So it is fairly complicated, I know, but each of these have to be addressed if you have any hope of getting that bunion deformity to slow down or stop from getting worse and worse, from going from stage 1, 2, 3, and 4. Here's a good example. This is just the bowstringing. At some point, once that toe moves over far enough, the extensor hallucis longus muscle will actually cause a vector pull to pull that even more that direction. Okay? That's why getting, alignment's going to be important. Getting this back on there to keep that straight is going to stop that vector from making that toe go crooked. Okay? So if you look at this, I just gave you a whole bunch of things. And they're all saying the same thing, that there is a misalignment and a muscle imbalance around the big toe joint. There is a lot of reasons for that. The bowstringing of the extensor hallucis longus is one of them, right? The gait, the ground reaction force vector during the gait cycle, the instability of the proximal segments of the subtalar joint, metatarsal joint at a time where I need stability. So all of these are contributing to the bunion deformity. Okay? This one basically talks about the first, or the medial column of the foot has an independent axis of motion. Okay? It has an independent axis of motion just like our hand does. In fact, the medial column of the hand and the foot have an independent axis of motion. The lateral column has an independent axis of motion. All right, that's why we can do that on our hand. Most feet can't do that, but they are mirrored to the hand so that the medial column has an independent axis, the lateral column has an independent axis. The deep transverse intermetatarsal ligament keeps these held together really tight so they don't do a lot independent of each other. Okay. The thing is if that axis deviates, all right, if it changes position, all right, it can go from a dorsiflexion inversion adduction position, which would actually make that go towards the second metatarsal, okay, to a plantar flexion eversion abduction. So the green one deviated from the black one just a little bit like this, and once it flipped, it's going to change the rotation of that big toe joint as it goes through its range of motion. All right? Well, what's going to change this? Go back to that picture again. If that foot goes up and down, if it pronates and supinates, this axis is going to deviate with it. So just by rotating the foot up and down, the axis is going to change. Okay? So again, depending upon the orientation of the axis of the first ray, as the first metatarsal dorsiflex, right, it's going to either invert and move towards the second, or it's going to evert and move towards the second. Okay? And again, it really depends on the pitch of that axis, the biomechanics of the medial column of the foot. All right? That's a pretty fancy way of saying that as the foot pronates and supinates, the axis is going to deviate with that pronation and supination. All right? The abnormal position is a pronated position so that now that big toe joint moves crooked when it dorsiflexes. All right? If I resupinate it, it will go straight. That's another way of saying exactly what she demonstrated to us. Right? As she pronated and supinated, you saw that big toe joint basically go crooked. Okay? Hallux abducto-valgus. This is the abducto part of the hallux abducto-valgus. Okay? It's basically, as it rotates, it's either going abducting or adducting away from that second toe. So the take home here is closed kinetic chain dorsiflexion of the metatarsal phalangeal joint, okay, where the hallux is held stable. It produces a frontal plane rotation within that joint such that there is a relative abduction and valgus rotation of the proximal phalanx on the metatarsal head. Right. And this is where the hallux abducto-valgus comes from. Okay. This is where the orthopedic surgeons came up with the terminology for that. And this is, I mean, you can see it right here. As that foot is pronated during propulsion, you can actually see the ground reaction. So here it's supinated, it's coming down to the ground. You can see a good arch. All right. Then as soon as that starts shifting that way, you can see the ground reaction force vector pushing like that, and you can see the big toe joint have a little bump right there because that ground reaction force vectors do it. We could watch her walk and it would look exactly the same way if you want to, right? This is just a slow motion version of that. And again, this is a very mild, you can see this is very early. This is a sports patient. She's a little more advanced, right? Stage 2, almost 3 now, HAV deformity. And so you're going to see that much more prominent on her than you can on this patient. All right. Another way of saying the same thing. If I have a stable medial column of my foot, okay, either from the pronatus longus, from the rotation of the joint axis that we just talked about, all these things are saying the same thing, that I should have pressure underneath the big toe joint. As I'm pushing down into the ground before that and pushing myself forward, my pressure should look something like that, right? It should be a center pressure trace. In a hallux abducto-valgus patient, what you'll see is that that pressure will actually be shifted over to the second because this whole medial column now is not functioning normal. It's not accepting weight, right? Just like she demonstrated to us too. She could not accept the weight on the medial column and go up on her foot if it was pronated. All right. So you'll see on a pressure analysis situation, you will see no pressure there. Another way of looking at this, do I need a pressure system, okay, or an ink mat? If this has been going on for many years, I can just look at the callus formation on the bottom of the foot, right? If they walk a lot and they have shifting or shearing forces, what you'll see is right where that red spot is, you probably will see a little callus or a thickening hypertrophic tissue of the dermis and epidermal area. All right? Again, if it's been there long enough and they have shearing forces. All right? Otherwise, you can do a pressure analysis and look, is this working or not working? Okay? So again, there are quite a few conservative treatment options. I didn't get into it, but don't forget there's also surgical options, right? You can go in there and cut that. You think I'm a big fan of cutting that tissue? Did you see the anatomy that we had? Did you see, the past 10 slides I just talked about? That's a pretty complicated area to go in there with a knife and start cutting tissue around and moving it around, right? That's why bunion surgeries, yes, if you're very good and you know what you're doing and you understand the biomechanics, maybe you can go in there and start moving vectors around and moving tendons and fixating them and screwing it back together and changing orientations. But that is so complicated. 9 times out of 10, you may straighten it and fixate it, but if you don't address the underlying problem again that we just talked about, from pronation of the rear foot, metatarsal joint, weakening the muscles and proximal, things like that, that bunion deformity is going to come back, right? The worst scenario is you just cause more pain, as the doctor, don't make things worse. But, conservative therapy really should be the first line, and it's probably going to be the most important line. Just because, I would never let a surgeon cut me, all right? The only time I would ever say, yeah, a surgery is warranted, where the patient walks in and says, oh my God, I can't take this pain anymore, right? I can't even walk anymore. I come in a wheelchair. Then you need to go in there and try to help that patient, all right? If somebody comes in and said, oh, I got a little bump here, I don't like the cosmetics of it, if you go in there and you screw that up, there's a good chance they may never walk again. And I've seen that, all right? They come in just for something as simple as a little bunion cosmetic, they think it's cosmetic, and pretty soon, 3 surgeries later, they're in a wheelchair because every time they step on that, they get excruciating pain. So again, conservative therapy is really important, all right? There's a lot of stuff here, but, a toe straightening appliance, anywhere from the HALLUFIX, just to any piece of plastic on the medial side is going to do it as far as toe straightening, okay? We mentioned before, change your shoes, all right? Get a wider shoe. Get a shoe that you can balloon, that's leather right there, or get a shoe that has stretchable material right there so it's not irritating it, all right? And then there's the whole biomechanics of, would I give a shoe like this to somebody who has a bunion deformity? Or would I recommend a shoe like this? All right, is this shoe doing much to create proximal stability at the metatarsal joint, subtalar joint, higher up? No, right? This is a mobility shoe. There's reasons I give mobility, that I want mobility to occur in the foot. But this particular shoe, if the patient walked in with a bunion deformity and they were wearing this, I'm like, maybe we should change your shoe, right? Let's get a little bit more stability back into that foot, right? Obviously, you got medications. And then, as a physician, I have a whole nother arsenal available. I can do prolotherapy, which is basically glucose injections into things. That's going to really induce an inflammatory response, just like platelet-rich plasma injections can, okay? Stem cells are the ones that we're doing a lot more lately, and we harvest stem cells out of the abdominal fat or the bone marrow, usually the tib or the iliac crust, with a needle. And then about 3 weeks later, the laboratory will send us back that patient's stem cells, and then we re-inject it back into that area, all right? And that we're talking about promoting cell growth and things like that. Now, is all of that going to change the biomechanics? No. But if I'm trying to get areas of arthritis to heal, right? If that, here's a good, if this toe joint that is so crooked starts to rub on one side of the articular surface for 10,000 steps a day times 20 years, what's the articular surface going to look like right there, right? It's going to be eroded. That's where stem cells come into play. I can actually try to get that articular surface to grow some cells, synovial cells back. Okay. Obviously, acupuncture, physical therapy, we talked about muscle strengthening, and then orthotic therapy. Okay. Or in my words, I still think orthotic shoe therapy because they have to work together. Is it okay? I forgot that I'm not talking into this. Can you hear me? Okay. As far as shoes and insoles and lasts, you know, a metatarsal pad or a transverse arch actually can help with the alignment. All right. So anything with a pad across the bottom is going to lift the transverse arch and plantar flex the medial column of the foot. Sound familiar? Plantar flex the medial column of the foot, trying to drop that down to stabilize it. Very similar to what we talked about with this. Okay. And then, of course, you can get, you know, shoes have a last built into them, right? A curve to the last. So this one, if I look at the bisection of the rear foot and then look at the bisection of the forefoot, I can see that there's a curvature to this last, right? Very few shoes anymore have a straight last. It used to be the old days, maybe kids' shoes would do that, to try to do that. Again, so the curvature of the last comes into play. So I can look at different shoes, how they're designed, and I can actually try to get a last that has more of a curvature that would take the stress off this medial side. So again, the shoe style, the shoe design, which is another word saying last. The last is what the shoe is built around. Can come into play too. Okay. Here's a good example. You guys don't have the shoes here, do you? This particular shoe, this material is stretchable. All right, it can actually not put any stress on there. It was originally made for our diabetic patients, so that if they did have a bunion deformity, okay, because usually a diabetic patient will have bunion and muscular deformities like hammer toes because they have muscle imbalances due to the neuropathies, usually a motor neuropathy because their neuromuscular system is being affected. So this shoe was built so that, you know, if you had one of those that looked like that, that shoe is soft enough that it's not going to cause an ulceration by rubbing on it. Well, if you just have a bunion, that's going to work just as well too. I mean, just because you don't have diabetes, it's still going to work. All right, same kind of thing that has Velcro can opened up. And again, you know, this is going to fit in most shoes. And I saw it today. You were walking around with a slipper or like a flip-flop on, and it was still fitting. But the difference between a lot of these shoes on this right here is they're called extra depth. So they have extra depth means that shoe has about that much more room in it. Seems kind of trivial, but it's enough that you can get foam in there, or that you can get a brace in there, or that you can actually wear a brace because I sprained my ankle, right? This is a diabetic extra depth shoe that I have on, but I also have a pretty big ankle brace on now too. And look at how it still fits in there, right? So certain shoe styles will fit braces much easier. But even this, which, you know, people always, you know, look at this one, oh, that looks really thick. It's not really that thick. And it's going to fit into most shoes, okay? I think some of the key is too that you're looking for a closure system that has the ability to open up, okay? Any of these, and it'll fit in this shoe too probably. Just because it has a closure system that can be opened even more. Both of these have a stretchable material that will open up and allow for increased room. So again, shoe design is just as important for that too, for HAV. All right. I'm going to skip bunion surgeries. You guys don't need to know about that, right? The only reason I would bring up bunion surgery is, you know, after the surgery, even though I did a realignment, is there still abnormal biomechanics there and abnormal forces? Yeah. So when that patient starts to walk again, you know, this is a good option, right? You can basically, it's a splint. It's no different that after I do an ankle surgery, I put them into an air cast walking cast, right, to stabilize that joint while I'm going through rehabilitation. So this is the same thing. This is a splint afterwards, but then don't forget, eventually they also need to get into this, right? I would have to argue that, you know, you should never wear this without this, because this is stabilizing the proximal segment. This is really doing a alignment and a functional rehabilitation, right? Allowing them to walk while that's moving. And then, of course, this has to work with this. So now we got three things I got to worry about. And then I have to also then go into the neuromuscular rehabilitation. Okay? Again, the ultimate objective of bunion treatment is to restore the function of that patient's toe. All right? Whether that's surgical or conservative correction. Right? We want that function to come back as close to normal as possible. Okay. I went through school in the 90s. We were taught that you cannot correct a bunion. The only correction for a bunion is surgery. Right? Once it's crooked, it's crooked. You cut the bone, put it back over, and screw it back together. That's how you fix bunions, all right? Even in this course, we had biomechanics 1, 2, and 3. This course, they said, you know, the best thing that they taught us, the best thing this could do is slow down a bunion. So maybe it's not as bad 20 years from now if you wear this, okay? What I'm going to tell you is, you know, that's really not true anymore, all right? And the reason is because we're starting to understand how these things work. You know, not only is it an alignment issue, it's a neuromuscular rehabilitation tool. All the gait labs in the world that do research on a foot orthosis are realizing that it is neuromuscular proprioception, neuromuscular feeling, the changing that this has to the bottom of the foot, and the muscle and joints response to that change is how these start to work. No different than this. Right? This is a neuromuscular rehabilitation tool. Right? If I can realign that joint, what's around a joint? I mean, what's in the joint capsule? There are afferent nerve fibers. There are nerve fibers going back up to the brain telling my joint where it is in space. Right? I know my hand's up. I know my hand's down because the joint capsule and the ligaments around that joint are sending a signal back up to my brain to tell me where it is. Proprioception, right? Where that joint is in space. Okay, if I have damage across the joint, like some of those bunion pictures looked at, do I have damage to the afferent nerve fibers? Yeah. Right? Is there muscle imbalance? Yeah. It's neuromuscular disease, right? It's neuromuscular rehabilitation that's needed in addition to the alignment, in addition to the splinting, in addition to the strength and stability issues, okay? So, you know, is there clinical evidence for this? Yeah, there is, okay? This particular research subject, they took 23 subjects. They had HAV grade 2 and 3, not 4. Most of the time 4, you know, that's that gnarly picture where it's bone on bone, and they can't even walk. So again, grades 2 and 3, symptomatic pain on the pain scale, all right? 23, this one actually is all women, I didn't know that. 23 women, age of 55 years old. They did computerized pressure analysis, all right, barefoot with and without the splint. They also took x-rays and did questionnaires, things like that. And then did their statistics. We don't need to talk about that. All right. So here's basically a baseline. Then they did a fixed splint, and then they actually did a movable axis splint. Okay. Here again is the X-ray evidence. Again, this is a pretty severe bunion deformity. You can see the deviation. You can see the sesamoids are shifted over, like we talked earlier. All right. The fixed splint in this particular patient, you see they didn't do a lot for that. And then here's the movable axis splint. Actually did a pretty good job at realigning that joint. Okay. Basically, the results of that research showed that there was a significant reduction in the intermetatarsal angle, right, and the hallux angle between the two conditions. Okay, baseline and splint, and fixed splint, and rotation splint. All right. And then they looked at the pressure analysis. They actually showed a change in the loads also, again, for between baseline and wear in this. This one in particular showing this fixed splint and the rotational splint. And again, remember what we're talking about is if the medial column is unstable, it just goes up and out of the way, and the ground reaction gets shifted over to the second, third, fourth metatarsals, and that's what you're seeing there. As opposed to if I have a stable medial column, going back to all the stuff, you can see the pressure should be underneath the first med-hard head. So again, the pressure analysis also agrees that the rotational splint actually brought that medial column back to normal function versus a fixed splint system. Okay? And finally, I'm bringing this up just because it reminds me that, you know, there are machines out there that do neuromuscular rehabilitation. This one's just called the Hoover 360, and it's primarily made for ankle and knee and hip rehabs, the big joints like that, okay? But, you know, you need to consider that this is part of that PASS system. I need to get that neuromuscular rehab done with stability, all right? We don't need a very expensive, fancy computerized system, although it would help if we had one, you know. But you need to think about, how am I going to do neuromuscular rehab on this patient, right? Do I send her to the physical therapist and they work on them and they actually say, okay, you know, go on the balance board or go up on your toes and keep that balance, right? Because, I mean, really, there's no reason why this type of system wouldn't work. This is a targeted system where it's just a computerized balance board. The computer controls this, and then they have a feedback mechanism. So here you can see they're actually asking them to keep that target in that area. So that that board's moving, they're trying to keep that motion. So, you know, you could have the patient going up on their big toe and take it through a fixed program, okay? You know what's good about that? Number one, it gives me a baseline, all right? You saw her, like if I asked her to go up on her toes, right? I'm gonna probably see all kinds of deviation here because she was fairly unstable and I asked her to do that, all right? So I get a baseline and then I start rehabbing. I start doing therapy, and this thing could be programmed to do the therapy. So maybe I have them go up on their toes and I say, okay, as it starts to deviate, I want you to keep that target. So now what's going on is they're firing their muscles. They're watching it. They're having that feedback mechanism as they're watching it to keep that target, all right? So now, not only do I get a baseline, I also now have a therapy, a programmed system to do that. And then finally, at the very end, you know, you could set your protocols to say, you know, are you back to normal? Or have you improved, whatever, 80% maybe, that's my target, right? This system will tell me. Without a computerized system, you really wouldn't know that, all right? Just because somebody goes through, you know, 2 weeks, 6 weeks of therapy doesn't mean that they can go back to the normal activities and stuff like this. And again, this is the same argument post-operatively. It should be done post-operatively after the bunion surgery, but it also could be done conservatively, right? If I'm trying to do a muscular rehab and get those peroneals back. I could also do this, and I could hook those EMG or surface electrodes up there, and I could actually assist them and have the therapist working with firing of those posterior or the peroneal muscle. Okay? So again, lots of options, but the important thing is I really need to keep addressing each of these. Pain, instability, strength, or, you know, pain alignment, strength, and stability. Okay? PASS. All right? So my recommendations, splinting works. All right? The research shows that it works over time. All right? You need to control the midfoot and rear foot mechanics with this. Don't do this without this. It's not going to work probably, not very well. Again, this will realignment, but this, you know, if you don't do the PASS thing, you're only going to be doing part of it and not the complete picture. You need to do neuromuscular control. You've got to get those nerves and muscles functioning together again. Because that big toe joint, if it's severe enough, if there's enough damage in there, it's probably functioning abnormally. The neuromuscular control is lost. Okay? Obviously, you need shoes that are going to allow for that to occur too. So again, these are the things that we need. Oh, I didn't do that. Okay? All right, we need to address the pain. We need to address the alignment. Okay? To me, this is more of a strengthening device. This is a dynamic splint that's going to allow that abductor hallucis muscle to start functioning better and not have the imbalance between the adductor and the abductor hallucis. All right? And then work on the stability issue, right? And that might be something as you could do the same thing with a pressure mat too. You say, okay, I want you to work on, you know, getting that medial column to the ground, right? That's really the peroneus brevis or longus. Okay, or if you had a computerized system, you could do that way too. But without the whole picture, you have really no hope of getting the deformity to come back or disappear, right? To get that correction to come back, I should say. So that's why they have this PASS system, is that I need to address each of these, okay? Not just address the pain with the surgery or address the pain with narcotics and pills, okay? If I want to treat this conservatively, I've got to address all quadrants of that system. So I think they're going to do a workshop something too right now.
Yeah, we have like 10 minutes.
You have 10 minutes to do a workshop? I would say a couple things. One is, if they have these here, is this the only one we have?
Yeah,
Oh, that's all right. It is of value to play with this right now before you buy a pair and destroy it yourself. Right? Destroy theirs. The reason is because these heat guns heat up really fast, right? And really hot. So if I sat there for a long time, I would end up boiling the water molecules out of this, and you'll see little bumps come up out of it. Clearly, you're probably going to change the mechanics of that. So, you know, you have to get a sense for this heats up really quick and cools down really quick. So once you get a feel for that, it'll be a lot easier for you to do that with a patient. And then same thing with that, with the bunion aid, you know, just get a feel for putting one on and how, you know, it can rotate, right? That axis of motion deviates, right? So you got to make sure you get the axis of that HALLUFIX pretty close to that first metatarsophalangeal joint axis. Because, you know, I've seen the patients walk in and they're wearing this thing up on top of their toe just about, you know. So you got to make sure that they understand how to put that on, and you have to understand it before they understand it. So, okay, you want to do that real quick? Or?
Excuse me. For example, in clinical, which kind of patient will be benefit with this spin? For example, how many degrees? Any reference for us?
A good rule of thumb is probably 16 degrees or less if you take the x-ray. 16. The Myers angle, for that I usually go by grade 1, 2, 3, 4. And I would still say it's going to be, you know, either 1, 2, maybe 3s. Depends on how bad. 4, never. You know, I mean, you know, you saw that one picture of usually rheumatoid arthritis. You know, they have that deviation like that. It's just not going to, you know, probably fix it.
A patient like this, is it too serious and not?
Really, how I address that? His question is how bad can it be? How bad can their toe be crooked? All right. The question is can you straighten it? Can you do it with your finger? Can you get that toe straight and then have it go through that range of motion? Okay. Quite oftentimes, if those sesamoids are deviated, all right, or you have extra bone in there where it just won't move anymore, this probably won't work. If you can get it to go straight and then have it go through its range of motion, this will probably work, right? But if it's too much force or there's an impingement there, remember there's a lot of soft tissue there too that it can be impinged on. That's reducing that, okay? So that's the answer is just see if you can correct it. If you can correct it, then this can correct it.